Good. Thank you so much, Deanna. So I am going to share some of the findings from a project that we've done that actually Deanna was on, and it focused on a team approach to educating nurses in rural areas. So I would like, of course, to acknowledge iPANEL right up front here, and in particular, Kelly Stajahar and Carolyn Taylor, who are the principal investigators on the iPANEL team grant, which is funded by the Michael Smith Foundation for Health Research, BC Nursing Research Initiative. And so there were a number of people who contributed to this study. Again, the Michael Smith Foundation, UBC in partnership with Selkirk College, and we are very grateful for the BC Nursing Research Initiative. You may recall that this was a fund that was given to the Michael Smith Foundation to administer. That was really a fund that was designed to improve the work life of nurses. And so, you know, what our reasoning in doing this project was that we were really very much interested in improving the work life of nurses in rural areas as they endeavor to provide a palliative approach. And as always with all of these projects, there are so many great team members that help to make it possible. I was the leader on this project along with Gail Potter, who's a nursing instructor at Selkirk College. We had a number of co-investigators, Tammy McLean, Cheryl Reimer-Kirkham, Gwyneth Doan, Deanna, who you just heard from, Barbara McLeod, and Kelly Stajahar. And then some research coordinators, Linnell Urbacher, Miranda Dalhusen, and Carly Drabo. And I want to show you some of my co-investigators because, of course, it's always so much nicer to see some faces when you're dealing with a webinar. This is Gail Potter on the right and Brenda Hooper on the left. These are instructors and clinicians in the Trail Castlegar area who were very instrumental in this project, along with Tammy McLean, who's also from Selkirk College. And then a couple of my research coordinators, Miranda Dalhusen on the right and Linnell Urbacher on the left, who worked so hard along with Carly Drabo to analyze the data and to really just make it all possible for us. So the purpose of this project was to use the best evidence to develop the capacity of nurses practicing in rural areas to provide a palliative approach to care for individuals and their families living with life-limiting chronic illness. This was actually a two-phased project. In phase one, we were to develop, offer, and evaluate a curriculum in a palliative approach that meets the needs of rural nurses in light of skill mix and staffing models across practice contexts of home care, residential care, and acute medicine. In phase two, which has been completed but which I'm not reporting on today, was to pilot an innovative clinical experience in which home support and baccalaureate nursing students partnered to provide care in a palliative approach for individuals and their families living with life-limiting chronic illness in the community who would not otherwise have access to home nursing care. And we'll be sharing the findings of phase two in not too long. So what do we mean when we talk about a palliative approach? Kelly and Pat Porterfield and Rick Sawatsky and a few other investigators did a large literature synthesis, and based upon what's in the literature on a palliative approach, they came up with sort of these three criteria. It's adaptation of palliative care knowledge and expertise for those living with life-limiting chronic conditions where there are uncertain disease trajectories. It takes an upstream orientation toward the needs of people who have life-limiting illness in their families. In other words, early identification that is independent necessarily of prognosis. And then thirdly, integration and contextualization within healthcare systems. For example, integration into generalist nursing practice. So when we talk about a palliative approach in this seminar, this is really what we're talking about. You'll see it used in different ways, I'm sure, as you've read different pieces of literature, but this is the definition we're working with. So just some background to why we did this study. For those of you who are familiar with rural areas, you know that rural nurses are called upon to provide specialized care within a generalist context, and that there are really few to no specialized palliative services in rural areas, and in general, nurses would say they feel ill-prepared to provide palliative care. And according to some of the research that we've done, in some cases this leads to abdication of care. In rural areas in particular, if some champions, for example, have prepared themselves well for palliative care and other more generalist nurses feel less well prepared, sometimes they'll abdicate that care to others. And of course, within a palliative approach, we're seeking to prepare all people to feel confident in this area. And of course, naturally, there are implications for work satisfaction and retention of the rural nursing workforce if people are providing care in an area for which they feel ill-prepared. And in this study in particular, we were not just interested in registered nurses, but in healthcare workers as well, because we know that these individuals provide probably the most direct and personal care within a palliative approach with perhaps the least preparation time. And we know that they receive little education, support, or recognition for the very important work that they do. There was a recent study in Ontario that suggested while healthcare workers felt well prepared for their role in general, 51% indicated that they needed more training in palliative care, and 63% felt a need for further training in chronic disease management. So you can see a palliative approach really crosses both palliative care and chronic disease management. So there's really some compelling evidence that we really need to help healthcare workers to feel more confident in this area. And it's interesting, we looked in the literature for any kind of studies that had tried to do collaborative education between nurses and healthcare workers, and there was very little in the literature. And this was so interesting to us because there's just so much literature on the interprofessional team and how important that is in a palliative approach, but very little being done with these key people in the area of a palliative approach. I'm not going to say too much more in terms of background, but there are a couple of articles, one in Advances in Nursing Science that talk about rural nursing and end-of-life care more in particular, and then there's another article in Palliative and Supportive Care that talks about rural nurses' experiences of providing a palliative care, and much of what could be extrapolated to a palliative approach. Finally, some of the work that's been done that really, it's almost like this idea of we're it when it relates to rural nursing. I owe this expression to Barbara Jean Buckley, who just finished her PhD at the University of UBC. And she really talked about this whole difference between rural and urban resources and how, you know, in the rural areas, you aim for a palliative approach, but it's embedded primarily within primary care. And then in urban areas, you have a palliative approach, you have primary care, but you also have this specialized palliative care. And what our research has suggested, and the article that I showed you previously talks about this, is that rural nurses tend to take a lot of ownership over the care of patients because they are it, and when things go well, that can be a very satisfying experience. But when things tend to go sideways, or if we have what we often talk about as a bad death, rural nurses suffer from that quite a bit. There's a lot of moral distress that goes along with a bad death that occurs in rural areas. So there's a lot of incentive to really help nurses feel confident in this approach. And so our research question was, can an educational intervention based upon best practices in a palliative approach improve nurses' self-perceived knowledge and confidence? And when we talk about nurses in this context, we're really talking about the family of nursing, registered nurses, licensed practical workers, and healthcare workers. So our methods, we gave a workshop. We did pre- and post-test measures using the Palliative Nursing Self-Perceived Competence Scale and a palliative care knowledge instrument that was developed for the iPANEL provincial survey. So we asked nurses pre and post both about their self-perceived competence and about their self-perceived knowledge. So, and then we also took these post-test scores and then compared them to normative provincial data that were obtained through the iPANEL survey, because this was a small sample size, and so we wanted to be able to make some comments. How does this sample size relate to the larger population as well? And you can read more about that survey on the iPANEL website. There are results on there. And then we further asked individuals about their qualitative experiences about the education and about caring for those with life-limiting illness. And so when we designed this curriculum, we had certain goals. We wanted people to understand a palliative approach. We wanted them to know about transition periods. We wanted to help improve skill levels around pain and symptom management. We wanted to build a common language and understanding of certain assessment tools. We wanted to help them understand the value of working together in the family of nursing and to help improve teamwork through case studies and work experiences. And so in designing this curriculum, we had 3 priorities: a focus on symptoms common to most chronic illnesses in the last year of life. We wanted holistic supportive care in an upstream approach, and we wanted the participants to interact and discuss how each nursing care provider could contribute to management of these symptoms. So you will see that these kind of map on to what constitutes a palliative approach in the diagram that I showed previously. And so all participants were given this kind of metaphor of the river and the upstream, with the patient and their goals at the center of that, and then focusing on the many holistic aspects of care as it related to a palliative approach in an upstream way. The key elements of the curriculum were these transition models. Participants were given standardized assessment instruments. They were provided with teaching tools for patients and families. We did work with a number of case studies that characterized chronic illness trajectories across time and over contexts. Common interventions and tailored interventions to scopes of practice. All participants were given a binder of resources to take back to their work sites, and then we did these inductive follow-up sessions drawing upon participants' experiences. And so really when we did this curriculum, we did what you would call blended delivery. So everybody started with a 1.5-day workshop, and then we had 2-hour follow-up sessions at monthly intervals held both in person and via distance. So that it was almost like a community of practice where people learned the knowledge, they went back out to apply the knowledge, but then connected back with one another so that they could talk about their experiences. And these follow-up sessions were a blend of case studies that I talked about previously that were, projected to take people along these transitions, but we also asked people to share their experiences. What are you learning about a palliative approach? What challenges are you encountering? How are things going? And so it was kind of these inductive case study types of sessions. When we did the workshop, we were very purposeful about setting a learning climate, and so we held it at the Muir Center. That's a Muir Center for Peace that's beside Selkirk College. We looked for a very aesthetic climate. This was the view, believe it or not, outside the window of the Muir Center. This is the Muir Center. It's a very kind of home-like, hospitable type of environment where, the kitchen was right there with all the refreshments, a very welcoming environment. We knew that people were coming to something that might be a little bit different for them in terms of blended learning and across the family of nursing, and so we wanted people to feel comfortable. And then we sat people in tables such that there was an equal distribution of healthcare workers and registered nurses so that they really had these nice little learning forums where they would learn together. And then we also had breakout sessions where they would deal with their various scopes of practice. So for example, if we first of all spoke about pain management, we would be all together in a group. Basic principles of pain management would be talked about across various chronic illness trajectories. And then people would have breakout sessions and then come back and share some of their experiences. So it was a very neat experience and, of course, a very reflective type of environment. So these were our participants. We had 22 nurses in total and 13 healthcare workers. You'll see that the healthcare workers in age were a little bit older than the registered nurses in general. Many of them were in the 46 to 55 age range. Of course, across nursing, we had primarily women. We had one man there. Great variety of years in current role. I think we had people who were brand new into practice alongside practitioners who'd been in practice. I think some had been in 20 to 30 years. So we had a great level of experience. And in all locations of practice, you'll see very common in rural areas to have people working across multiple work site contexts. And for the registered nurses, that was indeed the case here. 10 of the 22 participants were working across multiple sites. We also asked them about their experience and comfort with the dying. So we wanted to know if they'd had experience caring for a family member with a life-limiting chronic illness. The majority of nurses did not. Interestingly enough, the majority of healthcare workers did, 61%. We also gave them the Fromelt attitude toward care of the dying scale, which measures nurses' comfort with dying and some of their perceptions. And it's interesting, we thought we would do this pre and post test as well, but what we actually found is right at the very beginning, both the nurses and the healthcare workers who participated were very comfortable, showed very high comfort scores going in. So of course then it's not a very good discriminator as to whether your education has improved that in any way. So let me first talk about some of the quantitative findings, remembering that, of course, we track changes in both self-perceived competence and self-perceived knowledge. So these were the scores for the self-perceived competence, and these were pre-test immediately before the workshop and then post-test at the conclusion of the experience. So keeping in mind they had the workshop, they went out into practice, they were met in this community of practice, and so this was at the conclusion, which was, I believe 4 months later, actually, that the post-test scores were taken. On the left-hand side here, we have the 18 nurses. And these were their pre-test scores on a scale of 0 to 5. These were their post-test scores here. And then we did test these for significance to see if there were statistically significant differences between pre- and post-test scores. And you'll see, interestingly enough, there were no statistically significant gains within the nurses. But then when you look at the healthcare workers, even though it's interesting, if you know anything about statistics, you'll know that the smaller the sample size, the harder it is to achieve statistical significance. And with these healthcare workers, there were only 12 of them, but look at the gains that they made in terms of their self-perceived competence. So statistically significant gains in their self-perceived confidence in pain, in spiritual needs, in needs related to functional status, in ethical and legal issues, interprofessional collaboration and communication, personal and professional issues related to nursing care, and last hours of life. So basically all across the board, except for a couple of competence measures, the healthcare workers felt much more confident coming out after this education. So what about the normative comparisons for self-perceived competence among nurses? What you're looking at this graph here is we've got the nurses on the left-hand side. We've got the normal provincial sample on the right-hand side. And there were, from the data that we used here, there were 902 people in the sample. And with all these very busy numbers, the main message was that for nurses, when they went into this education, their self-perceived competence in treating pain was quite a bit lower than the normative provincial sample. And after the education, they were equivalent to the provincial sample. And so that's very good news. All of the other domains, interestingly enough, even though there's a fair bit out there about rural nurses feeling less confident, all of the other domains really going into the education, they were comparable to the normative provincial sample, which of course there were a lot of rural nurses in this sample as well, so that makes sense. And so in terms of the normative comparisons for self-perceived competence amongst healthcare workers, this was, again, quite a bit more dramatic results on this. The ones that were comparable on pre and post-test, meaning they were similar with the provincial sample right on pre-test, was pain, other symptoms, psychological needs, and last hours of life. On pre-test, on these red indicators on social needs, needs related to functional status, interprofessional collaboration and communication, personal and professional issues, they were lower than the provincial sample on the pre-test, and they were equivalent with the provincial sample on post-test. So again, good gains. And interestingly enough, in this area of spiritual needs, they were actually lower, they were at the provincial sample going in, and they were actually higher than the provincial sample on their scores at the post-test. So what about changes in self-perceived knowledge dimension? So that's self-perceived confidence, and we could argue that actually knowledge and competence, self-perceived competence, are actually two different domains. Nurses showed gains in spiritual needs, ethical and legal issues, personal and professional issues related to nursing care. So remember, in self-perceived competence, they didn't show gains. Self-perceived knowledge, they showed gains in all of these three areas. And the healthcare workers, again, similar to what we found in self-perceived competence, they showed substantial gains in all of these areas in self-perceived knowledge. Another way to look at self-perceived knowledge is the percentage of inadequate knowledge. And this was really how the provincial sample was, this idea of self-perceived knowledge was mapped. And so if you look at the results on the iPANEL website, they're reported in terms of what percentage of nurses would rate themselves as 0 to 2 on a 5-point scale. So 5 is the best, 0 is the worst. You ask them about how they felt about their knowledge in this domain. This was the percentage of people who would put themselves on 0 to 2. And there were actually some quite remarkable results in here initially. So when you look at the nurses going into this education, fully 44% of them would have rated themselves as inadequate on the domain of spiritual needs. That dropped to 11% afterward. Ethical and legal issues for nurses was at 72% going in, inadequate, 27% inadequate, self-reported inadequate on post-test. The healthcare workers, there were quite a few. Pre-test, you'll see 66% inadequate on disease management, dropping to 16%, 41% on psychological needs, dropping to 8%, 74% loss and grief support, down to 8%, and so on right down the list. So making substantial gains. Now, the thing to really remember, though, on this chart is that, you know, in the provincial sample, that would look quite different because you have a very large sample size, and so a percent difference really means something. When you're dealing with smaller sample sizes, you know, it only takes 1 or 2 people to make a difference of 8%. And so just to kind of keep that in mind as you look at this graph. But nevertheless, that's pretty substantial gains, I would say. One thing we were really interested in, because we saw this on the provincial survey as well, nurses in general would say, you know what, I don't feel very confident in addressing spiritual needs and ethical and legal issues. And for those of you that are educators, you know that it's one thing to know that people feel not confident in that area. It's quite a different thing to try and figure out what it is you should be teaching them, because it can really come down to a few things that create this enormous sense of not feeling confident. And so we actually analyzed the data over the inductive sessions and tried to understand better what were the challenges that participants were bringing forward, where they would say, you know, this is a real problem for me and I don't know how to address this. And it was interesting because as it related to spiritual needs, the participants would say, you know, supporting patients who are afraid to die, I do not know what to do about helping with that fear. And that's related to that idea of dealing with beliefs about punishment after life. Many talked about not knowing when to refer to a spiritual care provider, or how is it that we talk about spirituality in the context of care without feeling like we're proselytizing people. When it came to ethical and legal issues, Participants wanted to know how to negotiate and reconciling different wishes, how to deal with fears of addiction, a lot of challenges around the differences between sedation and euthanasia, how to advocate for patients when they feel like treatment is inappropriate. And so it had a lot to do with all of these issues around negotiating difference and differences in values and beliefs. So that's really helpful as we go forward, knowing how to build curriculum that meets nurses' needs a little bit better. I want to turn now to the qualitative findings. So we weren't just interested in how people rated themselves, but what were your experiences of the education and what did you learn? And so we had semi-structured interviews with 9 nurses and 7 healthcare workers. They were great interviews. You know, for those of you that have done interviews, when people really want to talk, they generally tend to be rich, and these lasted anywhere from 50 to 79 minutes. And so we asked them about their experiences of the education, the extent to which it contributed to their ability to provide a palliative approach, and what further educational experiences would assist. And I've just pulled off a few quotes to give you some sense of what participants said and some of the themes. One of the most common themes of what people really appreciated about the experience was the ability to normalize their experiences with care of the dying. And so a lot is written about nurses in rural areas and the isolation of their practice. And I would hesitate to say that perhaps this is also the experiences of those who are caring for the dying, because it is such a private and intimate experience. And so this participant talked about having lots of aha moments, just learning that the dying process is in so many ways very, very similar. And really about the giving of care and being with the family, being present, the worries, concerns, fear. And so this participant said, so I felt a sense of community in the palliative aspect of things. This participant said, I was thinking, this sucks, laughs, that I'm doing this all by myself when I go back home, and just how supported and validated and encouraged and all those things that I felt through the process, this education process. So being able to go, hey, why can't I just make this up at home? So this was an RN with 2 years experience who actually did go back to her workplace environment and start a community of practice so that she would have that same kind of feeling of support within her own workplace. The other thing that participants talked about was having a toolbox for broader horizons. So being part of this education just gave them that much more in terms of, well, several participants actually talked about this idea of a toolbox. This was a healthcare worker with 24 years experience, said, I never thought about this, looking at the full person and not just from, are they in physical or pain from their disease? Now looking at, well, they could have spiritual pain. I think it's just made me more in tune with my residents because I'm looking at this from a whole different angle, whereas before it was you're doing your care, you know they're in pain, but not really realizing that they could be in a different kind of pain. Another participant that was a healthcare worker now with 3 years experience said, now I carry that in my mental professional toolbox, and each situation is a conversation. Or when something comes up, I find myself waiting, pausing more, and waiting for my brain to file through and see what piece of information may come up. This was an LPN with 8 years experience. She said, I think the information we were given about different types of health, like, for example, spiritual health, kind of makes you, or it makes me, try to clue into all those other things, especially when dealing with families. You know, it makes sense that when people are struggling with something, it's not just about the person dying. There are other things in the background that are being incorporated into everyone's feelings. And so trying to get people to open up about those other things, it's something that I've started to do a whole lot more. One of the most gratifying things about doing the education was healthcare workers in particular, although our RN students really acknowledged this as well, is that people felt they were able to now enter the conversation, and they had the permission and the courage to do so, both within the team of the family of nursing and with patients. This was an RN with 4 years experience who talked about having the courage to now enter the conversation with patients. She said, I try to be more present with them and give them a chance to talk about any issues they're having or concerns. I know that there's one client in long-term care that has had quite a rough road, and he's finally passed away now. But it took a long time for him to head down his journey, and it couldn't go fast enough for him. He was suffering for so long and so much, and it was really hard to see him like that. So just being present with him and, to try and give him a few extra minutes to open up and talk to you. And so this idea of having conversations was a big part of the curriculum. This was a healthcare worker with 3 years experience. She said, I suddenly heard all of those layers of his agony and his fear and his concern. She was talking about dealing with a patient. And I opened my ears and opened myself up to allowing him to get a little bit closer, and he shared a few more things. I was able to ask him some of the questions from the chart. She was talking about a chart that they'd been given. After asking the right questions, we moved through 3 days of the most incredible conversations, where at the end of it, he thanked me, and he cried, and we hugged and spent some absolutely valuable time. And so that's what the workshop and those tools and those charts gave me, was the courage and the ears and the eyes to see and hear, so that I opened the door a little bit more, rather than standing there in my own fear and shutting him down. This was a quote from a healthcare worker about her courage to actually have conversations and permission now to be part of the team. She said, a lot of times we'll bring up a problem, and then that's where our job kind of ends. And that's when the LPNs and the RNs kind of come in and do that as well. But understanding what they're saying, she's talking about the RNs, and being on the same page, I think it helps diminish misunderstandings. So if you can know the language that's being spoken, you can actually understand it. This was an LPN with 1 year experience talking about the team. They, and she was referring to the healthcare workers, were empowered. They felt that they had this information and they could actually do something. Maybe they recognized how important things like positioning and chatting with the person or the mouth care might be. And maybe they also recognize that the things that they see are really important. The nurses do need and want to know what they're seeing, just the way that they would confidently talk about the care that they were giving from the first sessions to, my last session that I attended. It was just night and day. Like the confidence and the way they talked about the things they were doing when they were in the room with a palliative patient, it was obvious they had so much more confidence. Another theme that came up was the idea of now having access to some evidence-informed knowledge. This was an RN with 2 years experience who was saying, and she was talking a lot about the binder and some of the evidence that they'd been given. There's resources there at my fingertips. I'm a person. I learn more from doing. So I've read through it, but I haven't had somebody, for instance, who's had a spinal cord compression. Now I have little alarm bells go off when these symptoms come up. I say, okay, wait a minute, this is kind of sounding familiar, and I can open my book and be able to refer to it and know that there's something to turn to. Otherwise, you kind of just do a Google search, and we all know what Google is like. You'll get so much, trying to track some things on Google, and you end up going in a spiral. This was a healthcare worker that had a similar experience. If I was with one of my nurses that was administering something for a terminally ill or somebody that was close to death, I would be questioning her. So it would have been nice to have a little more knowledge prior to the workshop, because then I wouldn't be looking like a goof, right? Because I would question, what are you giving her? Why are you giving it? What is it going to do? Blah, blah, blah. So she was talking about now actually having the kind of knowledge where she didn't have to ask those questions anymore. The final theme that came through was this idea of also building capacity for rural palliative care. An RN with 2 years experience said, I learned the palliative approach and what that is, and having a conversation with the team was significant. Whether that's big change, I don't know, but I always believe in a little seed planting. You never know where it's going to show up. Also in building capacity, this was a healthcare worker with 3 years experience. She said, our coworkers who are hearing our stories of what we learned, they're curious. Now more of them want to take it, meaning the course. We brought back excitement, enthusiasm, information, some sharing, and that has ignited the interest in some of the other coworkers and the nursing staff, and we're recognizing that we're all the better for it. I think that's what is unfolding and coming into the culture. We as a team, we are improving ourselves because we are becoming more cohesive as a team. Even with our limitations and our schedules, we are aware that we absolutely need to row this boat together. And so those were some of the themes that came out of the qualitative analysis. It was interesting, though, because it wasn't all rosy. There were definitely some nursing family tensions as we went into this workshop, and they were very transparent about this on the qualitative interviews. Some of the healthcare workers, I think in particular, when they came into the workshop, felt that there were some exclusions. They didn't feel quite like they fit. And part of this, I think, was they talked about there being initially what they called like a foreign language. As they sat around those tables initially, there was so much of the conversation that they didn't understand, and I think it got better as the education went on, but I think it was very difficult for them initially. Others talked about some of the dominating of conversations, and I'll talk a little bit more about that in a minute. There were some things that came up that we weren't quite expecting. It was definitely challenging to accommodate the different levels of expertise. And we do wonder, looking back, you know, there was not a high degree of self-reported increase in competence on the RN workers. And so if we were to do this again, we might think a little bit more about how we would accommodate these different levels of expertise. And one of the things that we didn't actually anticipate was we used a lot of case-based learning. And the healthcare workers in general, that's not a part of their education. And so we learned a lot about perhaps orienting them better to case study learning so that then they could feel more confident going into that. We did have some unanticipated learnings in this project, and they were basically related to the challenges of distance delivery and workplace context. So I'll just talk about those very briefly. You know, very little evidence exists about the delivery of rural education through distance technology, which when I went into the literature, this just surprised me incredibly, given how, you know, this is really, I think, the way that we need to go. Participants in this study, they were relatively confident in technology, the nurses more so than the healthcare workers. 16 of the 18 nurses and 6 of the 12 healthcare workers had completed online learning previously, but hands down, participants expressed preference for face-to-face learning, particularly with the sensitive nature of the topics that we were discussing. And we tried all kinds of different modes of learning in this. You know, we tried some blended learning where there were actually some of the participants could come and participate on site, and then others joined us through distance technology, and it created actually kind of a spectator-like atmosphere where it was very difficult for those who were not in the room to participate appropriately. So it really got us thinking about these whole distance delivery challenges. And I tell you, we did not anticipate some of the technology challenges. I mean, thought we were in fairly large rural areas, but we had problems with bandwidth. Originally, we were going to do video teleconferencing. We couldn't accommodate that. Participants had, of course, challenges with their computers. So then we fell back to cell phone usage, but of course, people have limited amounts on their plans. And a lot of people told us that really learning from home, particularly when we were having these kind of community of practice conversations, that there were just a lot of home distractions that made it less than preferable. And so when we actually mapped our session attendance, we did this over 2 cohorts actually. In the first cohort of participants, we had both combined distance and face-to-face. In the second cohort, we had distance only for follow-up sessions. And the bottom line is here is we had much better attendance in the combined distance and face-to-face, where people could actually come on site and interact with the instructors once again. We got a lot of feedback on workplace contexts. So, you know, it's back to a palliative approach, the idea that it needs to be embedded within context. People had a high degree of frustration, and we didn't anticipate that in the education. Healthcare workers, I think in particular, were coping with multiple deaths without support. They had heavy workloads, poor symptom management, and challenging communication. And so sometimes these follow-up sessions ended up being a time to debrief and gain support as much as they were really about education. We couldn't really separate those out. And some of the participants found that incredibly helpful. Others found that this distracted from their learning, and so it was a bit of a tension to try and negotiate. So finally, some of the lessons that we learned from this project, curriculum and a palliative approach in rural areas really can increase knowledge and confidence. In this project, the greatest gains were made by the healthcare workers. There are huge team building benefits to joint education, but I do think we need to spend a bit more time preparing healthcare workers to engage, particularly as it relates to things around case-based learning, and just finding better ways to make them feel more comfortable initially when they come into the learning environment. And really the education was as much about building enthusiasm and capacity as it was about knowledge gain. And finally, learning via distance in rural areas really requires further exploration. So I want to finish with a quote from one of the healthcare workers that just kind of epitomized this project for me. She said, you know, at the start of my shift, prior to the education, I would say, oh, I hope they don't die on my shift. And now I'm kind of volunteering to take that patient. And so at the end of the day, I think if we can increase that kind of confidence and willingness in individuals, then that's a good thing. So thank you very much. That's the end of my presentation.